We will go ahead and start this evening. So good evening, everyone. My name is Dr. Amar Swali. I'm the consultant nephrologist and physician in Sri Hindu Mandal Hospital in Dar es Salaam, Tanzania. I would first of all like to thank the International Society of Nephrology, the ISN, for facilitating this talk and introducing us to tonight's speaker. It is my pleasure to introduce to you Dr. Ebun Bamgboye, who will be speaking to us tonight on the prospects and the challenges of kidney transplantation in Africa. Dr. Ebun Bamgboye is a consultant physician and nephrologist, and he is the head of the Dialysis Transplant Unit at the St. Nicholas Hospital and the clinical director of the same hospital in Lagos, Nigeria. Dr. Bamgboye has been employed at the St. Nicholas since February 1998, and over the years, he has developed one of Nigeria's most prestigious and functional dialysis units, which receives referrals from all around the world. He is also the head of the St. Nicholas Renal Transplant Unit, and this unit has been running for the last 25 years and was the first unit in Nigeria and the sub-Saharan region to perform successful kidney transplants, and so far have performed more than 350 kidney transplants. He is also the co-chair of the AFRAN, the African Association of Nephrology Transplantation Committee. Dr. Bamgboye, despite his extensive clinical work, is also involved in academic work, training resident doctors from various units, and is widely published in various articles in respectable journals and has contributed to chapters of 3 international books. He is also widely sought after as a resource person at various local and international conferences and symposia. Dr. Ebun Bamgboye is the president of both the Nigeria Association of Nephrology and the Transplant Association of Nigeria, and he is the leading authority in the transplant nephrology in Nigeria in the sub-Saharan region. Dr. Bamgboye, I would also like to acknowledge tonight on this panel 3 very senior consultant nephrologists, Dr. Francis Frederick Furia, who is a senior pediatric consultant nephrologist and rheumatologist at the Muhimbili National Hospital in Dar es Salaam, Tanzania. We also have with us Dr. Joseph Narindwa, who is a senior consultant nephrologist in Rwanda, and also Professor Rajendra Bhima, who is a senior pediatric consultant nephrologist in KwaZulu-Natal in South Africa. So I would like you to welcome you to start this interesting talk that we have this evening. So thank you very much and welcome.
Well, good evening, Africa, I should say. And welcome to what I hope would be an interesting 35, 40 minutes of a talk, talking around the challenges and prospects of kidney transplant in Africa. I also would like to acknowledge and thank ISN for nominating myself, and I'll be the first of 3 such nominees that would be participating on behalf of ISN in this Africa Health Network Fireside chat. And also to encourage all of us to join ISN if we are not already members of that international society. I think I would like to acknowledge the fact that they've been very helpful to nephrology in Africa in very many respects, and there are various ways by which they've made it easy for those of us in Africa to join ISN. And I'm sure if you speak with other members, they should be able to guide you as to how to go about this. I have no disclosures except to thank ISN and the African Health Network, the organizers, for inviting me to give this talk. But as had been said earlier, I happen to be the co-chair of the AFRAN Committee on Transplantation. And I would, on behalf of the chair of that committee, Dr. Malcolm Davis, use this opportunity to solicit for membership of that committee. We've been struggling to try and get members from across the continent, and you can contact either myself or himself if you are interested in joining the committee. I practice in Lagos, Nigeria, and I bring you greetings from Nigeria and from Lagos. Hope that sometime you'll be able to visit us in our little beautiful city. And also bring greetings from St. Nicholas Hospital, which, as you've heard, has been involved in renal care for the past 25 years and has pioneered quite a bit as regards renal care in our country and in the sub-region. And we happen to have been the first to have started off kidney transplants in the West African sub-region and have so far done well over 370 transplants. The outline of the talk would be to look at, give an overview of what transplantation is like in Africa, and if necessary, compare that with what happens in the rest of the world. Look through what challenges these various units across the continent are having in implementing transplant programs, and look at the prospects of expanding that and suggest some solutions. And if I have time, I'll go through what our experience has been running a transplant program at St. Nicholas, and hope that that serves as a prototype for those who might similarly want to do the same. And I'm hoping we'll have an active discussion and question and answer session after we've concluded the talk. Now, transplants have been around for quite a while, and the first successful transplant was actually done a little short of 70 years ago. This was done in 23-year-old identical twins, Ronald and Richard, and was done in Boston in the United States of America by Joseph Murray. As you might all recall, that recipient made full recovery. He ended up marrying one of his nurses and lived for well over 20 years with minimal immunosuppression, and in fact died of an MI, a myocardial infarction, with a functioning graft. And quite recently I read this, and I think the person who supported the writing of this paper is actually with us on this webinar. And it describes a diseased donor kidney transplant that was done 52 years ago in a 6-year-old. And at the time the patient was reviewed in September 2022, now 58 years old, the man still had his functioning kidney with a creatinine of 157. And this was from a diseased donor kidney. So it shows that transplant has been around with us for quite a while. But what's the situation in Africa? This map shows what the situation is. And if you look at the legend, which describes the numbers in millions per million population, you find that when you look at the situation in Africa, you find that most of us are in gray, meaning that either we're not doing transplants or there's no data available. And very few countries within our continent have either started off or have been able to sustain a renal transplant program. So if you decide to size the continents based on the number of transplants they've performed, you'll find that some continents will be oversized, like the United States and Europe, possibly Asia, whilst you'll find that Africa has shrunken and has become almost non-existent. So you find that in 2021, over 100,000 kidney transplants, or close to 100,000 kidney transplants were done in just that 1 year. But out of all these transplants, you find that Africa contributed only 1% to the total number of transplants done compared with the other continents in the world. So the Americas contributed about 40%, Europe 25%, Western Pacific about 19%, and Southeast Asia possibly about 11%. The US, of course, are the leaders in transplantation. They carry out the largest number of transplants. Last year, they achieved 1 million transplants. And 50% of those transplants were actually done sometime within the last 15 years. And 2022, last year, they actually carried out 25,000 renal transplants in just that 1 year. I always use this slide to reflect and to sometimes bemoan our challenges in the continent. If you look at the way the map of the world is presented, you always get the impression that our continent is a lot smaller than it is. But this actually reflects the true size of our continent, Africa. And you find that within that continent, you can actually fit in the whole of the United States of America, the whole of China, the whole of India, and practically the whole of Europe into what exactly is the size of our continent, Africa. And this second chart reflects what the world economy is in a single chart. And if you assume that the whole economy of the world contributes only about 80 trillion, you find that Africa's contribution to that is about 1% of what the whole world economy is. This little bit here, what the total amount of contribution that Africa has as far as the world's economy is. In fact, in that chart, only 3 countries are represented: Nigeria, Egypt, and South Africa. Now, meanwhile, we're a continent of 1.34 billion people. I think the world crossed 8 billion sometime late last year. We have over 54 countries. We're the cradle of humanity. We're endowed with immense natural and human resource, but yet we're the most underdeveloped of all the continents. And our share of the global economy is not just small, but it's unfortunately appearing to be dropping. And if you look at the 32 lowest spots on the United Nations Human Development Index, 30 of the countries in that index are countries here in Africa. The top 10 richest countries by overall GDP in Africa are listed here. And what's interesting to note is that they practically also represent the countries on our continent that are or have been carrying out regular transplants. So more or less, what is this suggesting? There's a strong relationship between the GDP and your capacity to start off and sustain a regular transplant program. Healthcare expenditure in Africa is a challenge. Private and external funds have become the predominant source of financing. And in 2017, 26 countries worldwide that relied on donor funding for more than 1/5 of their health spending were countries within our continent. And this is another chart showing health expenditure per capita. You find that almost all the countries within our continent are not doing as well as countries in other parts of the globe. This is despite the fact that sometime in 2001, the Abuja Declaration was made. The Abuja Declaration, African countries vowed to spend at least 15% of their GDP on health. And this was expected to help strengthen the health systems and ensure that we're prepared for disease outbreaks. But by 2016, the situation had actually deteriorated. And 19 African countries are spending less on healthcare than they did at the time when the Abuja Declaration was made. And this chart reflects the out-of-pocket expenditures percentage of the total health expenditure in 2012. And you find that almost all the countries in Africa are spending close to 50%, or about 50% of the countries in Africa have majority of the people spending anything over 40% of their, for 40% of the spend on health is out of pocket rather than from some either health insurance or from government. This is contrary to what happens in other parts of the world, where you find that the out-of-pocket spend is just that little pink spot that you see. The majority of them are either government or compulsory expenditure responsible for the health expenditure in such countries. And so it's not surprising that when you look at dialysis and transplant care around the world, that in this particular chart, even though Africa represents 17% of the world's population, only 1% this dialyze or have access to renal transplants within our continent. contrary to what happens in other parts of the world, US, the EU, and Japan. In the US particularly, the US spends about 50 billion looking after patients with kidney failure alone. And this is contrary to what happens in our continent. And I just, for example, used this study or this reports representing the situation in one of the teaching hospitals somewhere here in Nigeria, where it's seen that 53% of the patients could not afford to care for themselves beyond 1 week. 35% could not afford to care for themselves beyond, and only about 5% of them could afford care for more than 12 weeks. So it's not surprising that the consequence of that is that overall, almost 90% of our patients with kidney failure are dead within 1 month. And what is shown, and this is a study that was published in Transplantation, that the better your level of development, the better your income level, the better you're able to provide your patients. Just looking at this, you find that if you go from low income to low middle to upper middle to high income, presents whether or not kidney transplant is available. So of the low income countries, only 23% of them have kidney transplant available, as opposed to almost 90% of countries in the high income group. Registries, almost none in the low income countries, and the number of centers, small percentage compared to those in the high income countries. So what's the health-seeking behavior of people in our part of the world? This is quoting a study that was published on Nigeria. We find that many of us end up in either prayer houses, 30%, medicine vendors, 45%, visiting traditional healers, or even patent medicine stores for our care, all of which we know will provide suboptimal care. And just as an example, this is Dr. Juma, maybe from somewhere in East Africa, who can treat and solve many problems. And I would say that swollen body, which is likely to be kidney failure, is one of those, but the same potion that he uses to treat that is what he uses for court case, bad luck, and other such things. Our own herbalist here, finding with that, but it's also become quite sophisticated and it's there on his computer. Or some of the quality of the hospitals that we have. As the chart says, this is disaster just waiting to happen. Our reliance on prayer. This is a chart looking at the number of people who pray daily in different parts of the world. Only 1% in China, about 10% in France, 6% in the UK, 55% in the US. In my dear country, Nigeria, 95% of us pray. So what are the factors determining if you get a kidney transplant in our continent? They include what country you're based in and where in the country that you live in. So of course, if the GDP of your country is high, you're more likely to have a transplant program in your country than otherwise. If you live in the urban area of your country, you're more likely to have access to dialysis and transplantation, as we'll see in the charts that follow. Also, the health access and quality and the human development index of the country. So you saw from the previous that these are, the greater the likelihood that you'd have access to transplantation. Of course, you have to have a renal care program in the country. You have dialysis. This is the National Health Insurance Scheme extended to renal care. For countries where it's not, how wealthy you are in such a country is what determines you have access to dialysis and transplantation. The level of education, if you're male and if you're an adult, in our dear continent, the men are more likely to have access to dialysis and transplantation, and the adults are more likely than children. Then, of course, the number of trained nephrologists available in country, in that country. We've seen this slide before. And as I said earlier, it practically represents, these are the top 10 countries overall by GDP in Africa. And you find that every single one of these countries, possibly with the exception of Tanzania, are the ones that currently have carried out kidney transplants and probably are able to sustain it. And this chart looks at the Human Development Index. It looks at different countries in different parts, different continents. And you find that there's a very close correlation between your HDI and your capacity to be able to provide and sustain either a disease or living donor kidney transplant. So the more developed you are, the more the likelihood. And you find that most of the countries in Africa, the yellow round, of course, are very low on the HDI index, or the Human Development Index, and many of them do not have transplant programs, and those that have do very few. Of course, the challenge of the number of nephrologists that we have on our continent. Whilst in Western Europe, they have an average of 31 nephrologists for every million of their population, and about 22 in North America. We find that in Africa, we have just about 1 nephrologist per million population. Many of our countries don't even have a few. The few that have are more or less restricted to the urban areas. This is a study we published possibly about a few years back, looking at the number of nephrologists in sub-Saharan Africa. We find that we have very, very few. If you correlate that with the number of the population of such countries, you find that hardly would you find any that has more nephrologists per million population than 1 per million population. And despite the fact that we don't have enough, putting together, this was another study published in the book Nephrology Worldwide, where in Nigeria we decided to look at the number of Nigerians trained as nephrologists or trained in Nigeria who are practicing as nephrologists in different parts of the world. And you find that despite the fact that we have such a low number, many of our nephrologists have emigrated. They've gone on what you call the brain drain, or what we in Nigeria call the Japa syndrome. You find that even though in Nigeria we currently have about 230 practicing nephrologists, we have as many as 124 practicing in the United States of America. And if you add to that the number that are practicing in various countries in Europe, in the Middle East, even in South Africa, we find that we probably have more nephrologists practicing outside than are available to practice within Nigeria. But some other countries in Africa that have similar problems would be Egypt with 91, Ethiopia with 28, Sudan with 28, South Africa, and these are just within the United States of America. So what's the capacity for kidney transplant in Africa? I think this was published, I think, in KI sometime back. And we found that kidney transplantation, according to that publication, was available in 14 countries, which is about 34% of the countries of the region. And the average number of kidney transplantation centers is about 0.07 per million population. But as it is currently, these are the countries in sub-Saharan Africa in which there are established and reasonably regular kidney transplants taking place. So Ghana, with a population of, I think the population close to about 30 million now, have carried out about 22. Cote d'Ivoire, about 15. Cameroon recently joined the wagon and currently have carried out about 4 transplants. Sudan have a reasonably active program and they've done well over 1,000. Ethiopia, 137. Kenya, and I would want an update on this if someone can do so, about 580, and Mauritius about 387. So these are the countries in sub-Saharan Africa in which there have been recent transplants. So South Africa is the clear leader. They average about 300 transplants per year in both public and private hospitals. Sudan also carried out close to about 200 transplants yearly in about 6 units, 4 of them public and 2 private. In Nigeria, we've been carrying out transplants since 2000, pioneered at St. Nicholas. And altogether now, we have about 16 units, many public, 5 private, that are carrying out an average of about 200 transplants per year. In Kenya, they are the leaders in the East African sub-region, and they carry out about 130 in public and 130 in private hospitals yearly, or have a total of 130 in the past 5 years. That's the cost average in the various units. But you find, if you base the number of transplants per million population, find that there's a clear, even in the centers where transplants are being done, find that the majority of them, there's a clear difference between the situation in the northern part of our continent, with, of course, Egypt carrying out about 15.5 transplants per million population, followed by Tunisia, then, of course, Sudan, Algeria, Morocco, South Africa. And the numbers in the other parts of the continent generally are often less than 1 per million population. In terms of the number of transplant centers available, the number of transplants done, so, in a paper we recently put together, these are the figures these are the data that came out. So South Africa has been doing transplants since 1966. And they have roughly about 15 transplant centers. And they've done close to 10,000 transplants till date. The number they've done in the last 3 years is about 750. Kenya, transplants since 1978, 5th of July. They have about 7 transplant units. And we've done about 400 so far, with about 160 in the last 3 years. In Nigeria, we started off 6th of March in the year 2000, about 16 transplant units, and 1,132, and about over 500 in the last 3 years. Cameroon, of course, just joined, and they did have 1 center, which started off in November 2021, and done 4 transplants till date. So what are the challenges faced by transplant units in Africa? A significant and recurring barrier is the high costs involved in providing transplantation and follow-up care, particularly the cost of maintenance immunosuppression. And if we're going to change this, we have to find a way for government to get involved, which is the way it's done in other parts of the world. What are the peculiar challenges mitigating against successful transplant programs? One is the fact that it's a very cost-intensive form of therapy. Unfortunately, most of the countries in our sub-region have very low GDPs. The infrastructure and support from institutions is limited, and many of them are not covered by their national health insurance schemes, even when those exist. The knowledge of the disease conditions is poor. Accessibility to healthcare facilities is poor. And we have all kinds of religious and cultural practices mitigating against, access. And many of our people patronize alternate healthcare as their first choice. So ethnicity is a problem, and it's believed that individuals in our continent, when they access or have transplants, there's an increased risk of a delayed graft function and acute rejection. And several theories have been postulated as to why that is. I suspect that it might have something to do with apolipoprotein 1 gene, but we'll discuss that later. We know that as a cause of chronic kidney disease, contrary to what happens in other parts of the world where diabetes features a lot more prominently, quite a number of our patients have chronic glomerulonephritis as the underlying cause. And very often this is due to focal segmental glomerulosclerosis, and we know the propensity for that to recur. In our studies, over 97% of our recipients and donors are CMV positive, and we know that that's one of the common infections that could present as a problem for individuals not appropriately, prophylaxed against this. There's a much higher than the usual prevalence of HIV, hepatitis B and C, and other such opportunistic infections, which very often can reactivate and becomes a challenge if not recognized and managed appropriately post-transplant. Many of our patients haven't had appropriate management for their anemia, and many have been transfused. This very often leads on to the development of donor-specific antibodies, which makes the care of such patients during the process of transplant also a challenge. Many of the female patients have had multiple pregnancies, and this also predisposes them to the risk of developing such antibodies. Many of our patients present late. Many cannot afford appropriate care, particularly for the use of antibody induction in the process of transplantation. Many of our centers done very few transplants and have not done enough to acquire the requisite experience to be able to provide the care appropriately. And then not all centers have the capacity to do therapeutic apheresis, which is becoming an increasing important asset if you're going to be able to provide appropriate care in patients who require transplantation. But then there are other things that might be to our advantage, which we should try and take advantage of. The average age of our patients is much younger than the age of individuals in the developed world. The average age of patients on dialysis in UK, Europe, and America would be close to 60. The average age in most of our units is about 40. In our units, is about 43.7 years. So our patients generally tend to be younger. And with that, of course, comes fewer comorbidities that may make it easier and less problematic for you to transplant such individuals. We have much fewer females with the attendant issues of antibodies from multiple pregnancies. We don't have that many pediatric patients, which also can be a challenge because of the heightened risk of rejection in such young patients. All living donors for now. I think currently only South Africa has an active cadaveric donor transplant ongoing. And generally, our patients have not been on dialysis for long prior to the transplant, which is also to some extent an advantage. Not many retransplants, less of diabetes. So these are advantages that might make it easier for us to carry out transplants in our continent. Now, we did a survey of the transplant units in Nigeria. Like I said, we've done over 1,300. All have been live donors, and a few of the centers are now doing the donor nephrectomies laparoscopically. There's been some concern about commercial kidney donations, mainly for patients that travel outside the country. I think there's a celebrated case that is ongoing now in the UK. I think, in fact, judgment was delivered just today. Fortunately, most of the centers in Nigeria are public-based, and they generally tend to be small with limited numbers. So what we find is that the privately run centers in Nigeria are the ones that are more successful. They're mostly centered in urban areas. So we find they're either in Lagos, the financial capital, Abuja, political capital, Kano, also another commercial center. Generally requires an individual to drive this, who has to be somebody who's focused, motivated. And usually for the public hospitals, they have to have somebody high up in authority that also believes in the program and supports it. And generally, the advice is that you should have the backing and support of an experienced unit, which could either be local or international. So this is a list of all the units that have carried out transplants successfully in Nigeria. The list is about 16 of them. As I said, quite a number of them are in public hospitals. But what you'll find is that those that are based in public hospitals have done very few in terms of the total number of transplants being carried out in Nigeria. Nigeria is divided into 6 geopolitical zones: northwest, northeast, north central, southwest, south south, southeast. And you find that most of the transplant centers that are available are actually located within the southwest part of the country. And that is with the exception of the 2 financial and political capitals of the country that each have about 3 transplant units. In terms of the numbers, you'll find that almost all the recent transplants till date have been done, in about 3 or 4 of such units. You find that most of those are done in centers that are themselves located in private hospitals. And in fact, in the last 3 years, practically all the transplants, close to 90% of them have been done in just 2 of such units. The challenges of the transplant units based in public hospitals, they generally tend to be overstaffed, poor maintenance culture, work ethics, attitude to patients, there's interdisciplinary rivalry, and forever going on strike. Our experience at St. Nicholas, just go through this very quickly. We started off our dialysis program 26th of August, year 1998. And since then, the numbers of patients that we see have continued to rise. Last year, 2022, we saw close to 200 new patients presenting in that unit. And as I said, majority of them tend to be in their 40s, the oldest 85, youngest 7. Diabetics are increasingly becoming a common cause of kidney failure. And the mean age in this particular group in this year was 50 years. As I said before, there's almost always a 2 to 3 to 1 ratio of male to female. And the prevalence of infections like HIV, Hep B, and Hep C generally tend to be quite high. 1% hepatitis C, 4% hepatitis B, and as high as 9% of HIV in the patients that we saw in the year 2022. Over time, we've collaborated with different units in different parts of the world, in the UK, particularly Royal Free Hammersmith, University of Birmingham. And then more recently with units from India, Fortis Polo, and the United States in 2018. First transplant was done 6th of March, we've done 371. And generally, majority of them are genetically related. The youngest we've done is 11, the eldest 67, mean age 45, which almost a 3 to 1 ratio. And these are the numbers that have been done in St. Nicholas the last 23 years since we started off the transplants. Last year, we did 48 transplants, generally more men than women, and about the same age as the dialysis patients that we see. In terms of etiology, hypertension, chronic glomerulonephritis, but like I said, diabetes is becoming not an infrequent cause of kidney failure amongst our patients. Patients come from all over the country. The donors generally, of course, not younger than 18, and we've accepted in one instance, a 70-year-old donor, and generally tend to be slightly younger, more men than women. And in terms of the relationship, we try to be as careful as possible to make sure that we are certain of the relationship between the donor and recipient. And the majority of them have been genetically related with some emotionally related individuals. We do some of the donor nephrectomies laparoscopically. This is just one example of one. But despite the fact that we do transplants, many of our patients still go abroad, and many of them go particularly to India, a few to the UK and the US, a few to other countries, both within the continent, including Egypt and South Africa, other parts of Southeast Asia. So far we've done 371. Our 1-year graft survival is about 92%. 1-year patient survival is at 96%. 5 years, 68. 10-year graft survival about 36. In terms of post-transplant malignancies, contrary to what obtains in other parts of the world, the most frequent we've seen has been Kaposi sarcoma. Our patients that go abroad are generally those that we've rejected because either we're not comfortable with the stated relationship between the donor and recipient, or rejected for some other reason, and very often come back with multiple problems. One of them is this gentleman who went to Pakistan, had acute rejection, and was just put in the plane and sent back, lost the graft, and had to go back on dialysis. It's important that we recognize the Declaration of Istanbul on organ trafficking and transplant tourism. This is to ensure that we protect the poor and vulnerable in our different countries and guard against the sale of tissues and organs. I was privileged to be one of those that put together the Istanbul Declaration about 15 years ago. I think you'll find me somewhere there. Consequent on that, Nigeria has enacted a health act which has some provision for transplant. The concern, of course, is that the measures stipulated as penalty are a bit too lenient. So a person who removes a kidney or any other not replaceable organ, the fine is just ₦1 million, which in real terms comes to not much of a deterrent. And the individual who sells the part, the fine is just 100,000 naira. The only one that is a bit more stringent is if you take a kidney from a deceased donor, there you're liable to imprisonment for a minimum of 5 years without an option of fine. So what are the solutions, in terms of what can we as a continent do to ensure that we improve our numbers and outcomes? I think we must first accept that the provision of universal health care and renal care for citizens in our continent is a fundamental human right, which must be respected and implemented. So it's not a matter of if, but how and when this should be done. And then we as professionals must develop the capacity to deal with the full range of what is required to provide care. And this will range from not just hemodialysis, peritoneal dialysis, ensure we develop the capacity to do therapeutic apheresis, and eventually also renal transplantation. Should develop the competence to do this efficiently and cost effectively. And should be able to provide these services at cost-effective prices and at locations within the reach of all in both the urban and rural areas. One recognizes that the less privileged may have to have government subsidy, but then the privileged must be prepared to pay their due for these services. It should be ready and widely available. And once this happens, naturally the cost of providing this care would lessen and make it more available to more people. We should explore alternatives or technology to help reduce the costs. We shouldn't naturally adopt hook, line, and sinker, what is available in other parts of the world. We should look for ways of modifying things to make it cheaper for us to provide this care. Negotiate with providers of technology for reduced costs to the patients. I know this is something that India has been able to successfully do. What I find is very often the cost of medications, particularly post-transplant immunosuppressants that come from India, about half the cost of what we're able to get from the same companies that are coming out from Europe. Of course, recognizing that even the United States of America, with all the resources available to them, are struggling. We must recognize that it would be almost impossible to provide transplantation to everybody that needs it on our continent. So we should also focus on screening, early diagnosis. Early screening should be primordial, primary, secondary, and tertiary. Like I said, recognizing that no government can provide for all. And then encourage national health insurance to be available to provide this care. And this is something that Kenya has been able to do. Once the act supporting that was enacted in that country, you find that there are numbers in terms of the number of patients they have on dialysis. And transplantation has spiraled upwards significantly. So what does this mean in practical terms? We need to increase the number of dialysis units and provide these in all parts of the country, including the rural areas. We must train nephrologists, train dialysis nurses and technicians. We must improve the quality of dialysis by training and improving attitude and providing equipment. And once we establish that the patient is in end stage, we should be willing and able to transfer such suitable patients onto a transplant list or to units that have the capacity to do that. We must more appropriately manage anemia, avoid transfusion. We must provide appropriate nutrition, avoid femoral vascular access in such patients, avoid blood transfusions, vaccinate our patients, provide appropriate care for those that might be hepatitis C or HIV positive, and transition to renal transplantation as soon as the diagnosis is established. Because it's quite well established that the shorter the time patient spends on dialysis, the better the short and the long-term outcomes. And then be prepared to collaborate with established centers and collaborate amongst ourselves in there. Yes, you can go to Europe or America or India, but even within the continent itself, clearly South Africa, Egypt are centers within our continent where there's a wealth of experience that we all should be prepared to take advantage of. For instance, in Nigeria, where there are over 16 centers, and many of them doing no more than 2 or 3 transplants over a period, should we be looking at merging those centers and only certifying fit to do transplant those centers that do a defined number every year? But we should continue to train, audit, and monitor the various established centers. But more importantly, make sure we have the central registry relates to results and outcomes. Then, of course, we can then start talking about taking on the more marginal and complex cases, which naturally would be best managed in centers that have the capacity and experience to deal with such. Then look at various forms of induction and finding ways of making these more readily available at better costs. And then look at peculiarities of transplant in our environment. As a policy, we give prophylaxis against malaria, TB, cystic carinae pneumonia, CMV, Candida for up to the first 6 months post-transplant. Then ensure that plasmapheresis are available, should help with dealing with desensitized patients, of course, in instances where there's acute rejection. But ultimately, what we should be looking towards a disease donor transplant in Africa. I think the only country where this is done routinely is South Africa. But this becomes a bit more complex because it requires coordinated dialysis programs, capacity to do in-house tissue typing and cross-match. You have to have an organ procurement program and a call surgical team, capacity to fund the infrastructure and appropriate legislative framework that would guide such. These are things that require quite a bit of planning, foresight to be able to implement. Of course, I was pleased to see this shared on the African Nephrologist group, where in Mauritius, they've been talking about establishing a renal registry and starting off a disease donor transplant in that country, so that we're close to what happens in different parts of the world, where it's countries like Spain, they do as much as 38 a million population, similar in the US. Other measures should be to strictly follow up our donors to ensure nothing happens to them. That would encourage other live donors. We should enforce altruism and avoid a situation where commercial kidney transplantation is taking place. We should ensure that there's local ready availability of the various investigations, HLA typing and cross-match, the capacity to do drug levels, other things that might help to reduce the cost of care, carry out relevant research as to the peculiarities of doing transplants in our patients, and focus on prevention. So a lot has change in African nephrology over the last 30 years, because we've had various problems that are mitigated against us as a continent. We know that the pattern of illness has changed, and increasingly the non-communicable diseases are becoming more common. But our capacity and competence has definitely improved. Number of nephrologists, number of dialysis units, number of people with the competence to carry out transplants. And naturally, going on that, quality and outcomes have also improved. Kidney transplants have now become more widely available on our continent. So I'd like to thank you for listening in. And I always leave with this slide, which is of one of our earliest transplants. This was done 22 years ago, and the gentleman donated his kidney to his wife, shown in the picture there. Thank you very much, and I'll take your questions, comments going forward. Thank you.
Thank you very, very much, Dr. Bamgboye. And we will start with a series of questions from Dr. Valerie Loix. However, we do have Dr. Jonathan Ngumi and Dr. Elliot Tanner on the panel as well. So I'm hoping they will raise their hand up and ask a question after we are done with this. So from Dr. Valerie, she's thanking you for the fantastic overview of the spectrum of factors impacting a country's capacity to do renal transplantation. However, if you had to rank the barriers, how would you rank the following? How high would laboratory services rank with the ability to do HLA, DSA, drug monitoring, and how easy are these to get up and running in our environment?
Well, I'll use my center as an example of that. Without doubt, I mean, that is critical. And over the past 23 years, we've developed the capacity to be able to do drug levels, but we still have to send samples out of the country for HLA and cross-match. This, as you know, is a very essential part of the evaluation of the person towards a transplant. And it's also one of the more significant cost elements in providing that care. So there's a need for us to ensure that we can provide that service in country. The challenge we had is the numbers. For you to establish the cost of establishing the units would require that you're doing a significant number. It's something that we're looking towards now, that the number of transplants being done in country, in Nigeria particularly, is now well over 200 per year. I think that would justify, make it more cost effective to have such a unit. But the drug levels are now done within our hospital. The other challenge, of course, is the capacity to be able to do histology in the biopsies that we do. And for now, we still send biopsy specimens. I think, even though the laboratory is based here in Nigeria, they actually send the samples to South Africa. And sometimes there's a bit of a delay. You have the patient who you think has acute rejection, want to immediately start appropriate therapy, and you're having to wait 10 days. So most times what you've done is you've empirically treated, and the results of histology come back well after the patient might in fact have recovered, if you were right as regards it. So that's something else that I think needs to be done. And the way to go about that is to ensure that, yes, we've sent people for training, but they come back and all they're seeing are 2 or 3 transplant biopsies per month, which is not enough to sustain their skills in terms of interpretation. So that also requires an increase in numbers. And one is hopeful that as our numbers increase, it should be possible for us to have in country people that have the requisite experience to be able to interpret things like such tests. I hope that answers Valerie's question.
Thank you very much. So another question from Dr. Valerie is the Epstein-Barr virus post-transplantation lymphoproliferative disease a problem, or are most people IgG positive pre-transplant?
That's something else that I found quite interesting, in that the pattern of the various complications that you get post-transplant seems to vary depending on where you're from. We don't find post-transplant lymphoproliferative disease as a significant negative outcome in our patients. In fact, of all the 371 we've done, there's only one patient who has ended up with that. Hitherto, we have not been doing and on account of that, we haven't been doing the Epstein-Barr virus screening. Our patients are more likely to develop Kaposi sarcoma. That we've seen close to, not just amongst our own patients, but amongst patients who've gone elsewhere and done their transplants, well over 20 patients. As you know, that's much easier to manage. It just takes your modifying the immunosuppression, changing very often to sirolimus. You find that very often the outcomes are positive in such patients. So the answer, we don't routinely do the EBV, and we haven't seen PTLD as a very common outcome in our patients post-transplant.
Thank you very much. And a final one from Dr. Valerie, that she's suggesting that it is crucial to follow donors. So do we know if the safety of donation is any different in sub-Saharan Africa as compared to elsewhere? And also the longer term outcomes, should they be available or obtainable?
Well, there is some concern, and I know a few studies have been recently published in the US as regards the safety of living donors taking kidneys from people who are pro-lipoprotein 1 homozygous positive. We haven't done such studies, and I must confess that it's not one of the tests we routinely carry out amongst our potential donors. But what I have is the wealth of experience of 23 years of transplantation, and till date, there hasn't been any negative outcome to any of our potential donors. None of them have ended up with kidney dysfunction as a consequence till date. May have had other problems, or nothing related, we believe, to their donation. But it's something that is gathering momentum worldwide, and we're looking towards also including the screening of, for lipoprotein 1. But if you do that, the argument is that in Nigeria or in West Africa, the carriage of the G1 is about 36%, and for the G2 is about 8%. So you would find that immediately you reduce the number of potential donors you have to almost 50%. But of course, if this can guarantee the safety to donors, we all know that it's essential that we make sure that nothing happens to our potential living donors. Then that's something that we're already looking towards trying to do. But more importantly, we're in the process of carrying out a study where we look at our donors over the past 23 years and actually, find out what the lipoprotein 1 genotype is, and also then use that to monitor their renal function after. That's something that's in the works, which we are yet to conclude on.
Thank you very much once again. So we have two questions from two senior nephrologists in Dodoma, Tanzania, from the Benjamin Mkapa Hospital. We have Dr. Anthony Giunda. Dr. Giunda, I've unmuted you. Can you ask your question, please?
Thank you very much, Doc, for the opportunity to ask a question or to give an opinion. The presentation has been very, very good and educative. Actually, I've learned a lot of issues here, like the distribution of transplant centers in Africa, in some of the African countries. I just wanted to hear from the presenter if maybe you forgot or you never knew that in Tanzania we're also doing transplant. And so far, Mwimbili, combined Mkapa, we have done almost over 100 cases of renal transplant, live donor transplants. That is only what I wanted to share this evening.
Okay, that's nice to know. To be honest, I wasn't aware. The information I had was that the transplants there's a collaboration between Tanzania and units in India, and the patients actually go to India to have the transplants done. So the fact that you're actually carrying it out is news to me, and I will note that in any future talks that I might be required to give. Which hospitals are carrying out these transplants? That's for my information.
So we have two hospitals. One is the Muhimbili National Hospital in Dar es Salaam, which is the business capital, and then one is the Benjamin Mkapa Hospital in Dodoma, which is the political capital. So it's a budding transplant program that started in the end of 2017 and has been going on for almost six and a half years now. And they've carried out, as Dr. Giunda said, for about more than 100 transplants, about between 100 and 150 so far.
Okay, that's really nice to know. And it goes back to, if you look at my list of the top 10 countries per GDP in Africa, and my impression was that Tanzania, which was number 10 on that list, was the only country in which, so it shows that every country in that list actually have carried out transplants. And it's a reflection of what we also need to be looking towards. You know, clearly, one thing we need to do is to improve the economic outcomes and prospects for the different countries in our continent. There's one thing you can do that would improve the availability and outcomes. That's one thing I think we need to do. Thank you.
Yeah, Dr. Giunda has a follow-up comment. Dr. Giunda? So while we await his comment, we have Dr. Giunda's colleague, Dr. Alfred Maremo, who's also thanking you for a very good presentation. And he wants to address the issue of immune compatibility testing, which is still quite expensive and quite a challenge. And there are centers that opt to do transplants without performing these tests like DSA due to the cost. So what is your expert opinion on this?
Well, I think clearly, I mean, if you want to have the best outcomes, there's no way you can get away without a proper HLA cross-match and donor-specific antibody tests being carried out. And like I said, that's the only reason why for now in our program, we've still sustained our relationships with laboratories outside the country to carry out these tests. You find that it's quite critical to the outcome, and particularly in our environment where the likelihood of patients having such high DSAs is high. Many of our patients present late. Many have been multiply transfused. The women generally tend to have had multiple pregnancies. All these are things that we know enhance the risk of DSAs. And even in the instances where you've done a direct cross-match and it's negative, very often you find that by the time you're looking at the donor-specific antibodies, you find them MFIs in several thousands. So it's something that I think is critical. And what we could be looking at is, like I said, collaboration, finding a way of developing the capacity somewhere in Africa that we all can then take advantage of and build up the numbers to justify them, now probably having satellite units elsewhere. Having to now send the samples to, in our case, we used to send them to the UK. It's a considerable cost element. It ensures that the cost of the transplant is now such that it's beyond the reach of the average person, more so that these transplants are done out of pocket.
Thank you very much for your comment. We have another question from Dr. Brian Murray. I understand we have crossed the stipulated time for this chat, so I hope you'd be happy to continue for a few more minutes before we wind up. Dr. Brian Murray has a question as to how you were able to change the mindset and the beliefs and the cultural aspects in respect to organ transplant for your people to be able to agree and accept it as a form of treatment for better health? And also, what were some of the challenges you had to face along the way?
Sorry, could you repeat that question?
Yes, yes. So Dr. Brian Murray is asking how you were able to change the mindset, the beliefs and the cultural aspects concerning organ transplant in your country, and how were they happy to accept it as a form of treatment for better health? And also, what were the challenges you faced while achieving this?
Well, as in all things, I think in the initial stages, it was difficult. And the numbers, as you can see from the charts presented earlier, were 5, 6 in a year in the initial stages. But once you started off a transplant program, and you now have the wealth of several post-transplant donors and recipients, all of whom very often are willing and available to serve as counselors to encourage others, it becomes easier. And it now has become established that the risks are limited or not as great as they might have thought. And you now have a center that is doing significant numbers and outcomes are good. You find that almost invariably that encourages the donors. But it will take a lot of convincing if you're in an environment where not many transplants had previously been done. But increasingly now, I mean, I find that, in fact, very often what I have are 2 or 3 potential donors. I mean, I just finished a clinic this evening, and the gentleman I was seeing, his wife, he came with his wife and 2 children, a daughter and a son. And all 3 of them had volunteered as donors, mainly because they, of course, have seen or have heard of other patients that we have carried out transplants for. And the donors and recipients are doing well. So once you can establish a program, establish good outcomes, it becomes easier to convince people to take advantage or join the program and carry out the transplant in your unit.
Thank you very much. Professor Bhima from South Africa has a comment. Professor Bhima?
Thank you very much, Doctor, for that wonderful talk. I mean, it's really interesting because, that we looked at the GDP, we looked at the number of nephrologists, the number of centers, and that equates to, the number of transplants, etc. that done. But I just want to make a comment that one of the things that we are having problems with in South Africa is we are having a brain drain of nursing staff and other personnel related to the transplant team, like dietitians, social workers, psychologists. The hospitals are not employing enough of these, and transplant coordinators. And so what we've experienced in the last few years is that we are seeing a decline in the number of cadaveric donors because the fact that we don't have enough coordinators to go out and sensitize our ICU staff, etc., to organ donation. And I think that might be a problem that you must be encountering as well. So it is not, the point I'm trying to make is that there's a whole team involved in this. And, when you get one of those, the team members starting to be deficient, whether it be nursing staff, whether it be the other supporting members, transplantation just goes plumps downwards. You know what I mean? So I don't know what's your comment on that, because that's what we are experiencing firsthand in South Africa.
Well, I can confirm that that is an even greater challenge for us here. And to reflect that, I'd say that, I'm also fortunate to be the clinical director of the hospital here. And I can tell you that in 2021, we have 388 staff in the hospital. And in that 1 year, 110 of our staff left, which included nurses, doctors, pharmacists, IT people, almost everyone, all cadre of staff. And what that means is that more so if those are individuals related to the program, you have to start your training all over again. So it's a problem that we're having, and to be honest, I'm not sure how we can mitigate that. The slides I showed, there are probably more nephrologists practicing outside of Nigeria than there are practicing within the country. But the good thing is that we have an active training program for not just the doctors, but we have for nurses, we have for technicians. And the nephrology training program in the country actually churns out roughly maybe about between 10 and 20 adult and pediatric nephrologists every single year. So the unfortunate thing is that many of them will not be experienced, but just leaves the responsibility for the older, more experienced ones to ensure that they continue to train the younger, upcoming ones. And the other thing we are seeing also is that quite a number of those who've left after several years in Europe and America now get tired of living in a foreign country, and many of them are coming back. And hopefully, we'll get to a stage where the flux in is almost equal to the flux of those going out. But it is a challenge, and I suspect it would remain so for quite a while. And what we need to do is just to continue training. We need to train as many.
I fully agree. We are trying that. The problem is that the moment you train people, then they leave.
Very true.
Yeah.
You train them to a level of competence.
Yes, where they didn't find themselves marketable.
I think the UK particularly now is mopping them up like, particularly the nurses. Of those 110, 60 were nurses. 20 were doctors. About 8 were pharmacists. So you find that, it's a problem, but we don't have a choice. But we need to identify it and train to replace.
Thank you very much.
Thank you.
Thank you, Prof. Brima. I would like to invite Professor Francis Furia for a comment. Professor Francis.
Yeah, thank you so much. Thank you so much, Dr. Ebun, for this nice talk. We really enjoyed listening to the talk, and we could really relate to the challenges that we are all facing. And of course, we've had about 5 years of establishing kidney transplantation in Tanzania. And I guess the struggle that we are always facing is the fact that the cost of drugs, the reagents when you are establishing labs, and this has been a recurring problem that we are facing. And I'm looking at your setup where you have more than one center. Do you think it might be feasible to set up one lab that all your centers can use? If you have one center, one lab that is well equipped, which will be serving all the centers, do you think that is something that is feasible given the setting? Because I believe it is quite expensive when it takes time to send specimen outside. But if you have one lab in the country or in the region for that matter, would that be something that we might think of? Thank you.
Well, clearly that is something that we're doing. The hospital where I practice from has fortunately been endowed with the capacity to be able to provide a lot of solutions. Like, for instance, drug levels. We do that for most of the other centers. But, being a private hospital, privately funded, no grants from anywhere, setting up of a HLA and cross-match unit is quite cost intensive. But I think now that we're doing increasingly larger numbers, the belief is that we should now be able to make a business case to establish such a unit, either as a standalone or in collaboration with another unit. And those talks are ongoing. We have quite a few international related diagnostic centers here. And we've been in talks with 1 or 2 of them as to how they can go about with guarantee that we would supply them enough samples to justify the investment, go ahead and establish a unit that we can all then send our samples to. I think with the numbers now consistently in the last 3-4 years being more than 200 from the various units, I think there's a justification to go ahead and do so. So yes, that is the way to go. And ultimately, I think sometime within this year, I can expect that such units will be established.
Thank you very much. I would like to invite Dr. Jonathan Ngumi for a comment. He is one of the leads of the transplant program at the Muhimbili National Hospital in Tanzania. I believe he's just stepped out. I would also like to invite Dr. Elliot Tanner from Ghana, Senior Consultant Nephrologist from Ghana, to come in for a comment.
Yes, thank you very much. And Dr. Ebun, thank you for a wonderful presentation.
Elliot, hi.
I'm fine, thank you. A great presentation. Yeah, so I think like it's been said, I think one of the things we really may have to look at and get some evidence for is what actually happens to our donors. I don't know what your experience is like, but for some of my donors, even if you want to follow them, you don't find them. Apparently because clinically they are okay and they think in as much as they are okay, they don't need to follow up. So you might see them the first 3-6 months stops and that's it. They don't pitch again. I don't know what your experience is, because looking forward, I think it would not be a bad idea to get our own local data on how well some of these our donors are. And indeed, if they are good enough, they will be able to help us, solicit for more donors, since I think living related is going to be something that is going to be with us for quite a while. I mean, in Africa. What do you think?
Well, I agree with you completely, Elliot. Without any doubt, our donors very often, once you establish that they're fine and they come for the first few visits post-transplants, very often can be lost to follow up. But because in our program, we're quite strict. So invariably, it's either the wife, the husband, the brother, the mother, the child. So for as long as the recipient is there, it's easy to ensure that you can reach the donor if there's a need for it. And I mean, there are two things that I've looked at. I mean, before the hoopla about apolipoprotein 1, one of the things that I had wanted to focus on was to actually look at our donors that have the heterozygous inheritance of the sickle cell gene, AS. I'm not sure there's any widespread study that has looked at the outcomes for such. We accept AS donors, and I mean, without any definite study, I haven't found outcomes that are any different in them from what obtains in those that are not. But it would be nice to do a proper study and actually establish that that is happening. And that's something that we have looked into doing. And now that apolipoprotein 1 has come into it, we're thinking of piggybacking that also onto that study. So it's a study that we're in the process of putting together and trying to retrieve as many of our donors as possible. We have a pool of 371 at least. And if we add those that ended up going elsewhere, we could have a sizable number and just retrieve as many of them as possible. And try and carry out a study to see what the general outcome has been. And hopefully when the outcome of that is published, we should have some data that should be useful for the rest of the continent to take advantage of.
Yeah, that sounds great. Thanks.
Thank you.
Thank you very much. And the last one from Dr. Tomiwa Sotubo. I believe this is a pertinent question as to how the public and private sector can collaborate and increase the number of transplants done in the government sector. Any your take on that, Doc?
Well, I've said that is the way to go. The public hospitals in Nigeria, and I'm certain that that would be similar to most of the rest of the continent, have their challenges. And funding of such hospitals, the running of such hospitals, collaboration and interdisciplinary rivalry in such hospitals. So you find that, particularly in Nigeria, it would be nice to have a situation where there's some collaboration between the different units, public, private, to ensure that, public and private, to ensure that we can then enhance the knowledge and experience that such units have. In Nigeria, most of transplants are actually done in private sector. It would be nice for the public hospitals to collaborate with such private hospitals to ensure that at least the required experience is being garnered by those who are in training in, particularly the teaching hospitals. And that way you can enhance the training that those people get and enhance the outcomes. And more so if, in my unit, for instance, just 2 nephrologists, and sometimes the volume of work is becoming such that you wished that you had collaborating units that would help take some of that load off. And so we've been speaking with some of the local in Lagos teaching hospitals, and one of them has, recognized the need to send their senior registrars to do a 3 or 4 month posting within the unit. And that way, that collaboration, they go back with that experience. And that experience would definitely be helpful in developing the programs in such public hospitals.
Thank you very much. And once again, thank you very much, Dr. Bamgboye, for taking your time out and sharing your experience with us. I would also, on behalf of the Africa Healthcare Network, like to thank the ISN for facilitating this high-quality presentation. For our attendees claiming CPD points in Tanzania, the link is available in the chat box. We will also have a recording of this presentation available on our YouTube channel, the Africa Healthcare Network Fireside Chats channel, by Monday, hopefully. So please share the link when you get it and disseminate this presentation so we can get to as many people as possible. I would like to hand over to Dr. Lloyd for the vote of thanks and closing the session. Thank you so much, Dr. Lloyd.
Thank you very much, Bamgboye, for this wonderful presentation. And I'm extremely grateful to the ISN for having helped us out in bringing Dr. Bamgboye to this session. It was extremely well covered, very comprehensive session, covered the whole of the problems that are faced in Africa, and also the aspects of cadaver kidney transplantation, the issues that could come up, and of course the wonderful experience that has come off from St. Nicholas Hospital. Once again, thank you very much, Dr. Ebun, for this wonderful presentation. As Dr. Amar mentioned, we would love to have it on YouTube, and it should be there by Monday, and this will be there as a landmark for African transplant. Thank you very much.